So I'm Andy Davies. I am a lymphoma physician from the University of Southampton in the UK. I think this is a very significant concern of our patients, the worry about relapse disease. It's a very difficult time for patients at the end of treatment. We go through a very intensive period of time during diagnosis and then the treatment phase. And the patients have a lot of hospital visits and they have to deal with a lot of toxicities and a lot of anxiety around the outcome imaging results. There's a great fear of relapse amongst patients. And I think very often the time after completion of induction chemotherapy is one where there is particular concern. Patients go through a really difficult journey during the diagnostic phase of their illness and then the phase during immunochemotherapy where they have a lot of hospital visits for infusions, they may have problems with toxicities, they may have visits for scans, and then we meet with them to discuss the results of the scan and you hope that you're having a discussion with a patient about a PET scan that shows they've had a complete metabolic response, and that's really great. And you can say to patients that that's an excellent piece of news, they've had a scan that's good, but then you have to say to them, and the but is there is a risk of relapse for these patients. And that can be very difficult as patients try to rebuild their lives and they deal with the changes that have happened as a result of having been through this process. And they have this anxiety about recurrence of their disease. And we say to them, of course, the greatest risk of relapse occurs within the first 12 months after completion of therapy. It will get less in that second year, and then after 2 years, we know that the risk does decrease. But patients have to live with these anxieties, and I think it's a really important concern. And often the amount of support that we're giving patients sort of tails off a little bit at that stage because, of course, we're seeing them very regularly during the treatment phase. And then later, of course, we may say, well, I'll see you in 2 or 3 months' time for your next follow-up visit. And sometimes patients feel isolated and alone during that period. So I think patients, are worried about relapse, and we try to provide them with a high degree of support. And we have a team of specialist nurses. We also have access to psychological counselling to help give patients tools to sort of equip themselves with how they might cope with this anxiety and this worry. Now, it just affects people in different ways, and there will be some people who will be naturally more worried than other individuals about relapse. But we try to tailor that type of psychological support to an individual's need. But I think what's really important is that we don't underestimate that, and we talk to patients about this, and we try and put in the right degree of support for these patients. So, I give every patient the facts, the risk, the relative, risk of relapse for them so they can cope with that as, they can deal with it as they feel best. But the level of support that we might give around those conversations and ongoing will depend upon the patient's perspective. And I think, as I've said, some patients are naturally more worried about relapse than others. And for some, this risk of relapse concern can be really disabling and have an ongoing effect on their quality of life. I mean, I'm fortunate enough to work with a really excellent team of clinical nurse specialists who are trained to be able to give support for these. And for those patients who are most severely affected, then sometimes we may draw in some psychological support to help deal with that. But I think what's really important is that we recognize this and we give patients the tools to deal with it. I think what's important is explaining to them and making the milestones relevant. So I will say to a patient that the 1-year anniversary of completion of therapy, what an important milestone that may be. And then at the 2-year milestone, again, we'll reiterate that so that they know that their risk of recurrence at those time points has been passed and they're in a better place in terms of recurrence risk. So, I mean, we have good conversations with our patients. We build up a rapport with our patients during the treatment. We are very honest with our patients. And of course, what we do is we take in sort of the data that we have baseline about the patient, about their IPI, their biological risk, and we also take into account what sort of remission status they have achieved. And then we can give an individualized idea of the risk of recurrence. And I think, knowledge is power. And I think that's really important for patients that they understand that. I think the biggest thing, however, to tell patients is I can talk to you about population-based statistics. The only thing that matters, however, is what happens to that individual patient. So when we talk about what our surveillance strategy is in follow-up, how regularly we're going to see patients, what investigations we're going to do. And I think I always have a conversation with patients to say that we don't do any routine follow-up imaging. So I do imaging at the end of treatment, and if that demonstrates they've achieved a complete metabolic response, then I won't do any more imaging afterwards, because we recognize that that doesn't contribute, and more imaging just causes anxiety. So for my mind, it's about equipping the patient with the information and being able to have that discussion about how they feel about that risk of recurrence. So every patient's different, and so different patients will have a different perception on risk, as we all do in everyday life. And there are some patients who don't need any additional support afterwards, and some of them may require quite a lot of support. And so we really tailor that support according to the patient's desires. So, for example, we give the patients our contact telephone numbers to our nurse specialist team. So if they're worried about a symptom, they can always ring us up and we can review the relevance of that. We allow patients to have direct access into our clinic. I'm always very happy to see a patient who's worried about a symptom that may be suggestive of recurrence. And I think what's important is that we have an ongoing open dialogue with patients, and we tailor this assessment of risk, and we tailor the support that they need according to their own individual requirements. So I think information is really important for patients. So I think understanding they can recognize that they still may develop symptoms that may not necessarily be associated with recurrence, that they understand their own personalized risk of recurrence. So somebody, for example, who has had stage 1 disease with a low IPI score is going to be in a different risk profile to someone who's presented with an IPI score of 4 or 5, for example. So I think for me, the tools are some written information, some personalized information, the fact that they have access to the service, they have access to support nurses. These are the things that we tailor for the individual, which I think are the best for the patient.